the slide.
Okay. We welcome back. Okay, we take off the slide first, Felix. Show my face a little bit. So you unshare the slide first.
Can.
Okay, so we welcome back Dr. Felix again, yet again. And this is like, I've lost count of how many times he has done this spot diagnosis for us. But it's always so much fun and I get to learn so much and it's so interactive. And actually a lot of the participant knows quite a lot. So I think without further ado, we all know what is expected of the doctors who are in the forum. That is to guess, I mean, not guess lah, to say out the diagnosis because a lot of times they are not guessing. So come, Felix.
Okay, can you see?
Okay, we can see.
Okay. All right. We try to finish 15 cases today lah. See whether we can. Okay. Today's case is quite easy. I think most people can get most of the diagnosis correct. Okay. This lady come to me with 15 years history of this on the ear. What do you think she has on the left ear?
Oh, this one. Oh, this one I don't know. Okay, anyone? Is
Not
it
painful, nothing. Just
keloid?
unhappy with the appearance of the ear.
She's okay. We have keloid. We have keloid. Somebody said lipoma, radica. Radica, Queenie said keloid or lipoma. I've seen this before, you know. I think it's coming from the cartilage. Cauliflower ear. I think, yes, I think it's cauliflower ear. Though I don't know what is the pathology like. And I don't know why it's cauliflower ear, but I've seen this before. Anyone else? Anyone else? Chondroma. Chondroma. Okay, come on, guys. Anyone in Doquity is giving us the answer? It's only one ear.
Only one side, only one side.
And the ear, is it slightly deformed? Her ear looks a bit small and
her ear is like this, but this is the growth. Can you see the pinna is here? There is a growth coming out.
How long has this been?
More than 10 years.
Oh, it's not
It's slowly increasing in size. So it's hard, it's firm. So I think most of the doctors got it correct lah. This is keloid lah.
Oh, this is just keloid
this is keloid. Okay. So what do you think is the best form of management for this patient?
Wow, there's a huge keloid, huh? Okay, what's the best form of management, guys?
If you ever see Queenie said excision, ENT and plastic surgery, excise.
I think okay, there's intralesional steroid. I agree, steroid injection. Because if you cut, she will have more keloid. Okay, who else? Who else?
Makes sense.
Steroid injection, Lizzie Yung said, Hazana B. Hamza said that. Anna thinks it's excision. So this Queenie is quite good one now. Where is Gopi? Is Gopi around? Okay. Yes, Gopi, got nothing to say, Gopi. Okay.
Okay, so actually what I did is I laser it off and then I give intralesional intralesional steroids.
Sorry,
Now ears are quite good, but there's a bit of a problem because the thing is very, very big. So I cannot cut off everything. So you can see whatever is left, there's still keloidal tissue. That's why I are still giving her intralesional steroid. But because if we cut off everything, the ear will get deformed. Because if we cut everything, this part of the ear will go off. So I will just have to cut like this to maintain the shape of the ear. Otherwise, one side will go off. I think there was a big case somewhere a few years ago. Somebody go and cut a keloid and then half of the ear is gone.
oh my
So you
God.
have to be very careful. You have to be very careful when you do all this keloidal ear lesion. So the best treatment is still laser because minimal bleeding. Right. So usually straight after laser, I'll give intralesional steroids to prevent recurrence. If you don't give steroids, you almost always recur. So it has been 2 years now. The ears are still pretty good lah. I had a picture. I don't know where I put the picture. 2 years on.
But can I ask you what is the difference between a laser excision and a surgical excision?
Oh, you can cut, no problem. You can cut. The good thing about laser is that laser gives you coagulation. It coagulates the tissue, so I don't face with a lot of bleeding. If I cut, there will be a lot of bleeding. So I need to do I need to cauterize the bleed. So I don't have a cautery machine in my clinic. So I don't have laser. So I proceed on to laser. You can cut and do cautery, no problem. But it will be very messy because there will be a lot of bleeding. So I prefer you to use laser.
Okay,
I give intralesional kinocort straight after I cut, and I give the patient at least 3 to 5 times of intralesional kinocort. So I do every month for the next 3 months. And then I see, because this one, I didn't cut off everything. So every 4 or 5 months, I give her a bit of intralesional kinocort. But if I cut off everything, usually 2 or 3 intralesional kinocort, the treatment is done. Because the chunk of the keloid is very big. I cannot cut off everything.
Okay. Is intralesional cryotherapy
you can give intralesional cryotherapy, but you need to inject anesthetic agent, and then you need to inject your cryotherapy got a special head. You need to go through that special head, and then you spray cryotherapy until the whole keloid, this one, turns white. Then it will work, but it will be very, very painful as well. And then you have to do multiple times. You can alternatively inject kinocort in, and then you spray cryotherapy outside, but it's not as effective as putting in the whole cannula in and then spray the cryotherapy to make the whole thing turns white. This one is too big for intralesional kinocort alone. So it doesn't shrink. You need multiple times, and then eventually patient will have steroid toxicity. So I don't encourage you to keep on giving intralesional kinocort.
okay?
All right. Any other question you want to ask about this case?
No, so far I think it's okay.
Okay. All right. Next. Sorry. Okay, this case presents to me with this kind of lesion on the neck. What do you think? 2 to 3 years. I can't remember how many years, but 2 to 3 years. Agak-agak.
I think it's vitiligo. Gopi is back. Vitiligo. Yes, I think it's vitiligo. Young boy. Oh no, got mustache.
Young man, 25 or 26.
Yes, I think it's vitiligo.
Any other offer besides vitiligo? Okay, those who say vitiligo, can I ask you why you say it's vitiligo? I agree with you it's vitiligo, but can I ask you why you are so confident it's vitiligo, not pityriasis alba, not pityriasis versicolor, not leprosy? Why you are so confident it's vitiligo?
Oh, because there is loss of pigmentation. Okay, come on, guys. Okay, and there are areas that
Three person say vitiligo, they must have a reason they say vitiligo. It cannot be like tembak one. There
Yeah.
must be a reason behind why you say vitiligo. You're so confident you say it's vitiligo.
Skin is healthy. Okay, one person say because skin is healthy. Okay, I think it's because there are patchiness of pigmentation in between the patchiness of loss of pigmentation. Actually, I'm guessing only. Okay,
Yeah.
go.
When you
Hey,
look
come
at
on.
vitiligo, usually the hair follicle area will be the best to gauge whether it will grow back or not. This dot are the hair follicle. And when you look at hair follicle, the color, the melanin pigment is still apparent in the hair follicle. That's why when you your vitiligo repigment back, you pigment back with all these leopard spots. That's why you say this is vitiligo. Okay, very confidently this is vitiligo. So how do you want to treat this patient? How do you approach treating this patient?
Okay, can I just say that on the Facebook, Elfie say it because it happens on the neck. Is there one reason to suspect that it's vitiligo?
The vitiligo can occur anywhere on the body as long as there is a skin, even on the hair.
Okay. How would you want to treat this? Okay, anyone? Can we treat it? That's the question. Melanin.
How do you think you should approach this patient? How do you treat this patient with vitiligo?
Okay, first.
Meladinin pain. Okay, you can use meladinin pain is one of the possible option. Anything else? Protopic, very good. You can use protopic.
What's protopic? What is melanin?
Protopic is topical tacrolimus.
Oh, you mean like a
tacrolimus is the medication we give for kidney transplant, but this is a topical form.
Oh, I see.
Tacrolimus has a name called FK506. Topical steroid protopic phototherapy, very good. Unfortunately, I don't have the privilege of having phototherapy, so I do not have phototherapy in my center, so I can't give phototherapy. But if your center do have phototherapy, then phototherapy is a good option. Do either a PUVA or do a narrowband UVB. It would be very good for vitiligo. Very potent topical steroid. Yes, usually you can use. Yes, you you can rule out any other underlying autoimmune cause, but most of the time, segmental vitiligo with this, usually they do not have much of autoimmune disorder, but you can do autoimmune screening, no problem.
So what?
Anything else that you can use?
Hold on, sorry, I mute this Mr. Hing, Dr. Hing. Anything else? Melanin transplantation.
Okay, you can actually do a transplant if it is a segmental vitiligo, provided vitiligo is stable, it doesn't progress, then you can either use the skin culture to transplant, or you can use punch biopsy to graft, no problem. But skin biopsy to graft, it doesn't have a very nice effect. It's a bit leopardy kind of thing.
Oh, this transplant is from your own skin.
Yep. You scrape off your skin, then you culture the skin, and then you do a laser, and then you paint the skin back. Then the skin is a stem cell. Then it can take up.
I see. Okay, that that skin transplantation was a comment made by Dr. Sitopong Sarikun, I think from Dokwiti. So I think that from the name, maybe the doctor is actually from Thailand. Okay, Queenie say, how about mini dexamethasone pulse therapy?
I guess you can, but I don't use a lot of steroid therapy. I don't use a lot of steroid therapy, so I don't really like steroids, but I guess you can. So this patient progressed quite well. I give him a very old method of treatment because I don't have much of things at that particular time. I saw this patient like 4 years or 5 years ago. I don't have a luxury of having a very good treatment. So I gave him oral meladinine and then asked him to go under UV ray after like 1 or 2 hours after oral meladinine, check his liver function, ask him to put on the sunglasses on the day he's on meladinine, and then put him on protopic. Actually, this is 9 months down the road. This is almost one year, 2 months down the road. Can you see the repigmentation is quite good?
Wow, okay. I just want to make this comment. One is that this young man can actually be bothered about this discoloration at the nape of his neck, which is behind, to do all this. It's very weird.
Cosmetic, my friend.
But it's so it's at a spot that he can't even see.
Cosmetic. Nowadays, I do off-label use of JAK inhibitor, and I have a few patients who respond very well to JAK inhibitor.
What is JAK inhibitor?
Janus kinase inhibitor. Janus kinase inhibitor is a medication that we use for rheumatoid arthritis, psoriatic arthritis, atopic eczema, and then I use it off-label to treat this. JAK inhibitor also now labeled to treat alopecia areata. So I have a few patients who respond very well to JAK inhibitor, but the medication is very expensive. Very expensive.
Okay, what is very expensive like?
100 ringgit per tablet per day.
100 ringgit per tablet. So about 3,000 a month lah. And
Yep.
use forever?
You need to treat them until everything comes back. So you are talking about 6 months to a year.
Oh, I see. Okay.
Yeah, so it's expensive treatment.
Okay. Okay, good. Go on.
All right, this lady comes and see me, I think almost like 15 years ago. Multiple lumps on the left upper limb, painful. And she's a nurse in that particular hospital that I worked for previously. So what do you think?
Only one hand?
Only one hand.
Okay, Queenie says spirotrichosis. Okay, Dr. Ng said the treatment for vitiligo may not be permanent. I don't know whether he's a
Once the repigmentation comes back, usually that particular area don't lose its pigment. But of course, there are new pigment that can pop up, especially if you are talking about generalized vitiligo. You're right.
Okay. So this one says okay, spirotrichosis. I need to Google spirotrichosis. I forgot it was spirotrichosis. I know we did trichosis. Okay, anyone else? Oh, most people say spirotrichosis, huh?
Yeah, this is correct lah. So when you look at this lesion, one big lesion, and then it goes up like this is sporotrichoid spread. So this is sporotrichosis. Sporotrichosis is a fungal infection. It's caused by Sporotrix scankii. It is a zoonotic or a geophilic fungus. So it comes either from the cat or from the soil.
Oh, yes, we have done this before, but I forgot already. Yes.
Yeah. So treatment is with oral antifungal. So you need to treat the source. If the source is from a cat, so you need to treat the cat. If you don't treat the cat, the sporotrichosis doesn't clear, and then you need to treat it until you clear off, plus 2 to 4 weeks thereafter.
But how come it's so localized to one hand? Is it because she used that hand to pet the cat?
Most likely the cat scratch her or that particular yeah. Usually one hand only lah. Usually one hand only.
Oh, usually
Right.
it's okay.
Usually it's one side of the body only.
Okay.
Right. Next one. This patient comes with high spiking fever, and then she has swelling of the left side of the face, and then you can see the face a bit red. There's a bit of scarring here, red face, high spiking fever. So what do you need to suspect if you see this kind of patient?
Wow. Red face, high.
Very acute presentation. 1 day history of swelling. This one I come at midnight to see her. Very acute presentation, red face, swelling, fever, probably 1 or 2 days. Not feeling well.
She has
Having some
urticaria.
joint pain as well.
Oh. Okay, anyone?
Just by looking at this without blood investigation, can you agak feel what is it?
It says scarlet fever.
Scarlet fever usually tend not to have swelling of the eyes. It's very red, and then you get strawberry tongue.
Scarlet fever is caused by streptococcus. Is scarlet fever one of the reasons for rheumatic fever? Oh, yo, cannot remember lah. Okay, Dr. Kim.
Sinus thrombosis, maybe. Orbital cellulitis, maybe. But you can see the rash is here, the rash is here, the rash is here. Even on the filtrum, there is rash.
Okay, Christina said it's every.
Usually one-sided, but it's a good guess.
Okay, somebody said SLE.
Herpes zoster are usually one-sided, but this is like both-sided. Because this is both-sided, so very unlikely. It's herpes zoster. Steven Johnson usually don't present with swelling. Usually they present with redness of the eyes, and usually there will be target lesion. Yep, she do have a bit of angioedema, but angioedema doesn't give you that rash and that scarring here and casting.
Vasculitis.
Yes, you can get a bit of vasculitis here. Somebody says scleroderma. Scleroderma tends to be very tight. The mouth tends to be narrow. The
Not
tends
so
to be
acute,
big.
right? Not so acute.
Not so
right?
acute. Dermatomyositis is a possibility. Yes, allergic contact dermatitis to the product she used is a possibility. But usually they don't get high spiking fever, getting unwell, but it's a possibility. So when you look at this rash looks like a butterfly. And then you get angioedema and urticaria. The first thing, and then you get a scarring lesion here. The first thing you have to look out for is SLE. Somebody put there SLE. So this patient, ANA highly positive, double-stranded DNA positive, all her blood tests suggest full-blown SLE.
Oh, SLE also can be so acute, huh?
Yep. They can present with acute LE. This is an acute LE lesion. So I just put up to let people know that SLE can present with like all these allergic contact dermatitis kind of picture, so that you keep in mind that. But this is a typical case of SLE. Mala rash, vasculitic, something like vasculitic lesion, or your DLE lesion, swelling of the face. This is typical of SLE. Actually, the ears all got discoid lupus lesion. I didn't put the ears up. Okay, but when you see the patient one go, then you need to have an index of suspicion that this is SLE only. You get you see the ears, you see the hair and all those things. Otherwise, you just say this is contact dermatitis, this is herpes zoster and all those things. You miss the diagnosis.
But I think
The eye swelling is related to urticaria and angioedema related to SLE, because SLE itself also can cause urticaria vasculitis. It can cause swelling of the face.
Dr. Sutopong said it's lupus cutaneous.
Yeah, it's a acute cutaneous lupus. Acute cutaneous lupus. Yes. This is acute LE.
Hello, baby. What's her name again? I forgot. Okay, Dr.
Eleanor.
Eleanor. Oh my God.
Eleanor.
Is this Roosevelt's wife's name?
Yes.
Okay, what is the cause of the eye swelling?
Yeah. It's urticaria vasculitis.
Okay. Soon she will be able to do dermatology. Okay, let's go on.
All right. So
Okay,
this patient, I didn't proceed to biopsy the patient because all the blood tests comes back C3, C4 low, ANA positive, double-stranded DNA positive. I didn't biopsy the lesion. I didn't biopsy this patient. I just based on blood investigation.
So the fever in itself is the disease process?
Yes. It's part of the disease, and she do have a joint pain as well.
Okay.
Right, so this is full-blown SLE lah.
Yeah, you did mention joint pain, but nobody, so only one person. Who was it who guessed SLE? Huh?
Yeah, this is a difficult diagnosis. This is a difficult diagnosis. It's just putting up only lah. It's a diagnostic a challenge a bit lah. Okay, next. This patient comes to me 2 times. Same problem. What do you think this patient have?
Gonorrhea. Anybody?
No discharge per urethra. It's just swelling, blister or pustule here only.
Oh, it's
2
not
times, 2 times, same problem.
Oh, it's not
1 month apart. Asked him to do something, he forgot, and then he do again, and then the thing came back.
Fixed dark erection. Come on, cannot be lah. This must be a naughty guy. I don't know. Must be some STD.
Betty, everything there is not STD, okay?
Okay.
Then our urologist will talk to you about STD.
Okay, gangrene. I didn't say fixed drug erection. I said fixed drug reaction. Okay. Okay, come on. This is a serious, serious. Let's go on. Anyone else?
I think most of them get it correct lah. Fixed drug eruption lah. This patient took azithromycin for cough and cold, and then see me, I say don't take erythromycin. 1 month later, go and cough and cold, go and give azithromycin again.
I mean, this is a really fixed drug eruption.
Yeah, this is fixed drug eruption.
How come everybody?
The wife come with him and then scolded him the whole way during the consultation. Scold.
Because
and I say, hey, relax, this is drug, this is not STD, okay?
Oh, the wife herself thought it was STD.
Yeah lah. If it is there, most people think it's STD lah.
Yes. Oh, how come everybody knows it's fixed drug reaction? Do you know that
these people very young already, very good already.
my sister also has a fixed drug eruption due to Celebrex, you know?
Yeah. Acoxia more common than Celebrex. Acoxia more. But you can get fixed drug eruption with bak kut teh also.
Huh?
Yeah, because bak kut teh is herbs. Any herbs can give you fixed drug eruption.
Oh, lucky thing I don't. Oh, this is very
Nice.
interesting, huh? Poor guy.
Yeah, so this patient didn't listen to advice, so go back, give him allergy card, also didn't show the treating doctor, go and give azithro again.
As I see. Oh, this is so interesting. Okay, let's go on.
Okay, so this lady came to see me with this kind of rash. Has been following up in government hospital, one of the government hospital for many months lah. But come and see me, very acute on wheelchair, very painful, cannot tahan. Eventually we get her admitted lah. On presentation, having some fever, really complain of severe pain, including some joint pain. What do you think this lady have?
Pustular psoriasis. Okay, anyone?
Multiple areas. I just took a photo of this only lah. Multiple areas.
Anyone else? Queenie and Queenie is very active in dermatology lah, but actually anyone else? Sweet syndrome, Pei-Sei-Xiong, erythema nodosum. Pei-Sei-Xiong is new. I've never seen you before. Matters is new. Stephen Johnson. Oh, Yu Jian, you are here. Acute generalized exanthematous pustulosis. Hey, you change your diagnosis, Winnie. Wow, long one. Neutrophilic dermatosis. Okay. Some more, anyone else? Yes. What's your diagnosis, Eleanor?
So this one,
Okay,
she
wait, hold
has
on.
had it for some time.
Cystinia
This is a pustular psoriasis lah. But whatever is written here like AGEP, neutrophilic dermatosis, all these are differential diagnosis. But this patient has pustular psoriasis. She do have psoriatic plaque. She do have joint changes. She do have nail changes. I just didn't put up lah. Okay, so this is pustular psoriasis. Yeah, so because if I put up, definitely can get the diagnosis. So we need to challenge ourselves. This is pustular psoriasis. So she was given trial of acitretin, trial of cyclosporine, trial of methotrexate. It doesn't work. I put her on biologics. After 2 months of biologics, everything clear off. Now she's still on biologics.
Do you know that my first encounter with biologic was from your webinar? I never knew there was such word, biologic.
Okay. Sorry.
Okay, go on.
All right, this young boy come to me with this lesion that is bleeding. For the last night bleeding, today see me, but he has been there for almost like 1 or 2 weeks. Keep on bleeding, and then the father have to go to A&E, and then they need to press it. So what is it?
Okay, pyogenic granuloma pyogenic, which, okay. Wow. Anyone else? Pyogenic granuloma. So, this is simple. Everybody say the same thing. So
This is pyogenic granuloma lah. Pyogenic granuloma. So how do you want to approach this patient? How do you treat this patient?
okay, tell me what is pyogenic granuloma first.
Pyogenic granuloma is an abnormal blood vessel lah. Means normal is not a is not infection, is also not a granuloma. It's just a abnormal overgrowth of a blood vessel.
Oh, so this is a very misnomer lah. Pyogenic.
Yeah, it's a misnomer. It's a misnomer. It's associated with some hormonal changes. You see it more common in pregnant ladies. You can see it in isotretinoin treatment.
So Christina says strawberry nevus is not the same, is it?
Strawberry nevus is not. Strawberry nevus is congenital. But this one is pyogenic granuloma is different.
And you
So
should,
they are right. You can do cryotherapy, you can use diathermy, you can use electrocautery. The easiest one is you can use CO2 laser, you then do excision. You can choose whatever you want. The one that you are okay with, you know how to do properly, then you do lah. But cryotherapy, you might need second and third session. So in children, cryotherapy might be a bit of a hassle because every time you need to do second, third time, the child don't like you. And then the child will don't want to come back to you. So usually we try to do one off in children.
and this one can happen in any age.
You can happen in any age. You can happen in adult also, no problem.
Oh, I see. So it's not a child thing. Is it not the same as
it's not a child thing.
Is it?
It's not a hemangioma. It's not a hemangioma. Hemangioma comes in infancy. This is not hemangioma. This is pyogenic granuloma. It's different.
So what's the pathology? I mean, to come out suddenly this abnormal. Is
That's
it?
why we are not sure. We are not sure. We think it is due to trauma or hormonal change. We are not sure why it comes out.
But it is
multiple
truly,
theory.
But it's truly an abnormal blood vessel.
Yes. It's only an abnormal blood vessel. There's a feeding blood vessel, so you just need to do laser to blast it off. You can do either a CO2 laser or a pulse dye laser. Pulse dye laser also can use to clear it off.
So it's not painful or anything lah.
Usually bleeding only, they'll come with bleeding.
I see.
The bleed can be quite severe, the parents might go to A&E middle of the night because bleeding non-stop.
Okay.
Okay, next, this uncle came to me with this kind of skin lesion, slightly itchy for the past 2 months. What do you think it is?
Oh, I cannot. I don't even
Is it the uncle is quite fat, cannot, or you cannot see the skin lesion?
Okay, I cannot make a diagnosis. Okay, somebody said okay. Queen SJS. I don't know what's SJS.
Steven Johnson syndrome.
Oh, bullous disease, pemphigus vulgaris, mastocytosis. Okay, cannot. I know we did pemphigus or pemphigoid before our last webinar, but I can't remember.
Bullous pemphigoid, we did it. So this one, when you look at this, it's all crusted. And then you can see some blister that just come down. And then there is no surrounding erythema. This is pemphigus vulgaris. I biopsy and confirm.
Okay, this Zephan limb just come in already can get.
Yes, pemphigus vulgaris, correct. This is pemphigus vulgaris.
Okay, can you again tell us pemphigus, pemphigoid, are they the same group of disease or they are completely different?
All these are blistering disease. Blistering disease is divided into acquired blistering disease or hereditary blistering disease. Bullous pemphigoid, pemphigus vulgaris is the most common acquired blistering disease. Usually occurs in middle-aged elderly gentlemen. Bullous pemphigoid usually will start with urticaria, very, very itchy. Then after that, we call it urticaria plaque, and then they'll have a very flat, very tense blister. Pemphigus vulgaris, very, very soft, very, very flaccid blister. Then after that, it will pop, and then it will give rise to all this crusting. No erythema or urticated plaque earlier. Pemphigus vulgaris can affect the mouth. Bullous pemphigoid usually don't have any oral ulcer. But so there are variants.
Autoimmune?
All are autoimmune. So we do a skin biopsy, then we'll do a IF. The IF will do a direct immunofluorescence. Then we need to see a fishnet appearance or a chicken wire appearance on the direct immunofluorescence test.
Okay, for the hereditary bullous disease, can give us
Yeah.
some example?
Usually hereditary is epidermolysis bullosa.
Okay.
It's divided into level, whether it is a superficial, mid, or deep level. So all these hereditary one, usually you get it in children, infancy, and the deeper it is, the more likely you will scar. Some are not compatible with life.
Oh, I see. Oh, so sad. Okay, let's go on.
Right. So this patient comes to me with this on the left thumb. Right thumb, sorry. Right thumb. Right thumb. So, right thumb. What do you think he has?
Your daughter corrected you.
Sorry. I have left disorientation. So my car always park on the right, and then I will go to the left, and my daughter will say, "Daddy, you put your car on the right side."
Okay, somebody's okay, people say paronychia and Queenie say chronic paronychia. Paronychia is a infection of the nail bed.
Paronychia is inflammation of the skin surrounding the nail the nail fall, we call nail
I
fall
see.
inflammation.
Okay, I agree. I also think it's paronychia.
Chronic paronychia or acute paronychia.
Okay. Okay, so Gopi.
Chronic paronychia means it has been going on for some time. Usually there will be loss of cuticle, but this one cuticle is still there, and then it's very swollen. So when you see cuticle is still there, it's very, very swollen. So most likely this is acute paronychia. So what I did is I chuchok, and then you can see pus coming out. This is acute paronychia. Treat with oral antibiotic, release the pus, and then you'll get better. Of course, you can do an IND if you want. So I just chuchok a bit, and then the whole thing came out.
This must be real
And
painful.
you know the pus coming out?
Yes.
Yeah. So you can actually do a incision and then do a IND if you want, but the kid is very scared. He's I think 14 or 15 years old. So I just grab the hand to choke a bit, and then the pus come out. Problem settled 1 week later, he came back, everything normal already. So this is acute paronychia. When you look at chronic paronychia, usually you have loss of cuticle, you have eczematous kind of changes around the nail fall. The whole nail fall here is eczematous. It's usually your people who are in contact with constant water contact, hairdresser, house maker, homemaker, all these people, usually they'll have chronic paronychia. And usually it's not bacterial infection like this, it's usually fungal infection. Right.
Okay.
Next, this is a Myanmar patient. Myanmar, I think, yeah. Myanmar patient came to me with this face, and then I did examination of the cuticle nail fall cuticle. What do you think this is? If I put like this, it's very easy. Sure get diagnosis one. Those who have done dermatology will get the diagnosis.
SLE. Bisation.
If you cannot get, then habis already. This is pure dermatology and rheumatology.
Stress already everybody did not even make comment already. Okay.
No lah, it's just to have fun only lah. Just to have fun only. Just to have fun only.
Okay. Hold on. So Dr. Sitopong asked whether how does it different from FELON? What FELON? I don't know. I think
sorry.
How does it different from FELON?
For which case?
I think it's the previous case lah. For the nail and maybe. Okay, now we settle this one first. Okay, that Nadia asked if it can happen in toes, same management. Yes, yes.
Yeah,
Pyrorhizia can happen anywhere as long as there's nail and there's the nail bed and the nail surrounding. Okay, Ratika says scleroderma. Scleroderma. SLE. Scleroderma, dermatomyositis. Dermatomyositis and SLE, I think should have more rash, right? I think.
Usually dermatomyositis and SLE looks almost similar.
With rash and one
Except
flaring.
like dermatomyositis, you see a lot of like your heliotrope rash, and then on the scalp is very red. Then you can get the shoal sign. You can get the mechanic's hand. All
Okay,
these are features of dermatomyositis.
something that you have mentioned before, dermatomyositis and SLE, something that is sparing the fish.
Oh, that one is on the hands. You can either get the rash on the knuckle, or you spare the knuckle. If you get the knuckle, Gotron sign is dermatomyositis. Spare the knuckle is SLE.
No, how about this labial fold? This fold here.
Dermatomyositis usually don't have this butterfly rash. Your SLE do have butterfly rash.
Okay.
So this patient has SLE. You can see the nail fall is all sudden cut off of the nail fall, and then it's a bit swollen of the eye. Initially, also, I don't know whether it's dermatomyositis or SLE, but they are from Myanmar. I cannot do a biopsy for them because it's too expensive. So I asked them to go and do a ANA double-stranded DNA and ENA panel. So it came back as anti-Smith positive. I can't remember. Anti-Smith positive, ANA positive. So I diagnosed her to have SLE. Her total white also a bit lowish. Her total white is around 3.7.
Okay, if it's scleroderma and SLE, is the treatment the same?
Scleroderma is different. Scleroderma is because that tightening of the skin. The treatment is totally different. SLE, usually you just give steroid, immunosuppression, hydroxychloroquine, prevention of sun exposure, and all these things. And then look out for complication of SLE, especially the kidney involvement.
Okay.
Dermatomyositis when you reach around maybe 40, 50 years old, then you have to look out for underlying malignancy.
Oh.
Because dermatomyositis is associated with internal malignancy. We had one case that had dermatomyositis. Eventually, we found her to have stage 1 breast cancer. Cut off the breast cancer, the dermatomyositis clear out by itself.
Oh, very interesting.
Okay, next. This patient present to me with multiple bogey lesion on the scalp. What do you think? He just give me he just came to me and said, "Doctor, bogey lesion on the scalp for 1 month. Please treat me." That's it. I asked everything negative.
Secondary syphilis.
It's bogey, it's bogey. So actually, what I did, I put a needle in, I suck, there is pus inside.
Oh my God.
What do you think? He has no cats at home. He has no pets at home. He never touched any cats at all. First time I see him, I really don't know what is it. I just tell him, "Ayo, ada jangkitan kuman dekat kepala lah."
Ray Y. Ong, cardiology, say alopecia areata. I think this
No.
lucky thing you're doing cardiology, okay? Okay, no. What else?
Anything else?
Okay, wait, let me guess. There's one word I came coming to my mind, but I can't remember. Lipidermatous scalp. Tinea capitis. Okay, tell us what is alopecia areata.
Alopecia areata usually comes as a patchy hair loss. Usually you don't have abscess. Usually you don't have abscess.
Alopecia is actually hair loss. So this,
Alopecia is hair loss. Areata means is patchy hair loss. So if you get alopecia areata, you always have to rule out secondary syphilis because it looks almost similar.
oh, I see. Somebody said necrotizing folliculitis. Somebody said infected pilar cyst. Somebody said tinea capitis.
Yeah. All this is in my mind. I treated him with antibiotic. After 2 weeks of treatment, not getting better. Treat another 2 weeks, change antibiotic, not getting better. And fortunately, the wife came to me, and the wife say, "Doktor, dia ada bagi tahu kah? Dia pergi Turkey buat hair transplant."
Oh my God.
Then he didn't tell me. So this is Mycobacterium abscessus infection.
TB.
From the hair transplant.
TB.
Mycobacterium abscessus is a non-tuberculous mycobacterium. So now I treat him with the non-mycobacterium treatment. He's getting much better already. Because I cannot culture. I culture 3 times negative culture.
So this is a common, one of the known.
One of the complication of hair transplant is due to sterility of the place.
I see.
So I tell him, you untong satu, rugi satu lah. You got hair, but then all this infection comes in, no?
So how long is the treatment?
You need to give treatment for at least 6 months.
Wow.
It's just like TB treatment. It's just like TB treatment. I got a lot of patients with Mycobacterium abscessus. Most of them got it from the soil. But this one got it from hair transplant.
Okay.
So this is Mycobacterium abscessus infection from hair transplant done in Turkey.
Okay. So
okay, very interesting case. I put this up because I also don't know the diagnosis initially because I asked everything. He didn't tell me until the wife came in and our wife got the big mouth and tell me this thing. Then I got the diagnosis.
Okay, so somebody say furunculosis on Facebook.
Furunculosis is just basically infection, hair follicle infection, which is all correct. But hair follicle infection is usually caused by normal bacteria like Staphylococcus, Streptococcus. Usually you treat them with cefuroxime, augmentin, unacin, they'll clear off. I treat him with augmentin high dose, cefuroxime high dose, unacin high dose combined together with clindamycin also doesn't clear. Including I suck out the pus because he refused to let me cut.
I see. So how do you eventually got the Mycobacterium cultured?
It's very common. I didn't culture. It's very common.
Oh,
if you read the internet, it's very common. Mycobacterium abscessus is same kind of presentation almost always with hair transplantation. So those of you who do hair transplantation, please be careful, yeah. Okay, so
Dr. Parichat, no, the diagnosis was made by the fact from the clinical history only, not by culture.
Yes, clinical history. I didn't get to culture. I didn't get to culture. I sent it for Mycobacterium culture also negative.
And David,
because I treated the patient. If you have told me earlier before I started treatment, maybe it will be positive.
Oh, I see. Okay, so David, why shouting here? Sorry, what is the diagnosis? The diagnosis is Mycobacterium
Mycobacterium abscessus.
Furunculosis. Wow.
Okay, this is a presumptive diagnosis. Okay, next one. This patient comes to me with this kind of skin lesion. Last one already lah.
Yeah, last one already lah.
This patient comes to me with this kind of swelling on the face. What do you think she has? Painful, bulgy, soft.
Soft. Elena, you're soon going to be a dermatologist lah. Auntie give you the certification, okay? Okay, anyone? Anyone? Infected dermal filler site. Oh, possible, yeah.
Very
Good.
good, Christine, very good. Strep
Very-
cellulitis. Cellulitis tends to be flat, doesn't tend to be like bulgy. This is bulgy, it's more like abscess.
Panniculitis. Wow, this Ray on cardiology, panniculitis.
Panniculitis also possible, but panniculitis tends to be more indurated, usually not bulgy, it's more firm.
Yeah, I know what this
Infected
patient did.
sebaceous cyst, yes, possible, but there are very many sites.
This patient maybe did trading. Is it possible?
I actually also asked her, did you do trading? And then she gave me an answer. No, I go to India, I did liposuction, and they inject fat tissue, my fat into this is fat transfer.
My God. So post filler. So the filler is from her own. Oh,
So
this
it's her own fat. So it's again cosmetic procedure complication.
was
So I culture many times, this one also negative.
wow. These people very daring. I saw one case also, a young lady in her 30s. She had osteomyelitis because of this plastic surgery
Cosmetic,
procedure.
yeah. So whenever you do a cosmetic procedure, please be careful, because a lot of times they do cosmetic procedure, they don't want to tell you, and then they'll end up with us, and then we'll ask why. Only at the end they'll tell you, oh, I do this.
Okay, how would you treat this patient with antibiotics?
Oh, I treat her with antibiotic, but I really don't know what is it. They consulted the patient back in India. They say give linezolid. But I need to actually culture Staph aureus, and then only sensitive to linezolid, only I can give linezolid. Otherwise, how I don't have an indication to treat her with linezolid.
What is linezolid?
Linezolid is like vancomycin lah. Is given for
MRSA?
multi-resistant Staphylococcus aureus.
So you never got a culture for her?
I never got a culture. The first day she came to me, I aspirated everything. I didn't get a culture. So I admitted her for tauzosin for 10 days. And then did IND. I referred to the plastic surgeon for excision for IND. She refused IND.
Wow. So now is she still seeing you? Is it recurrent?
After discharge, never come back. I think probably changed doctor already lah.
Oh my God. Okay, maybe.
So whoever see her, please help to treat.
Okay, one more case lah. I also want to know the next case.
All right, this case just the orthopedic surgeon just referred to me this morning. Both leg painful, swollen, and then I see this on the feet. What do you think is the diagnosis?
Scabies. Crusted scabies. Wow, I went to orthopedic surgeon. Scabies at
Yeah, I went to orthopedic surgeon because treated as cellulitis.
Scabies. Oh my God.
Yes, Tempo and Queenie and Gopi, you are all right. This is Norwegian scabies. I told the orthopedic surgeon, please wash your hand.
Why? When this is a local gentleman?
This patient is alcoholic. He has alcoholic liver disease. So his immune system is poor. That's why he end up to have Norwegian scabies. So he's now in the ward. I'm treating him with permethrin and salicylic acid, because I cannot use our ivermectin. So we need to treat like this. Ivermectin is one of the treatment for Norwegian scabies.
Oh. Why on the leg and not on the hands? Usually on the hands, right?
Hand not much. Hand there is a bit of burrows. It's also involving the genital area. The genital area is something like this.
Oh my God.
Yeah, so this is Norwegian scabies. He has had this for 2 months. So normal scabies, we only have 12 scabies mites. Norwegian scabies, millions of mites. So you scrap this, there will be millions of mites.
You have shown us before this Norwegian scabies, but I think it
I've
was
shown before. Yes, I've shown before.
On the hand.
Yeah, so this when you see this, just be careful, because a lot of times admitted to the ward, the nurse touch, never wash hand, and then everybody end up having scabies.
Oh my God. Okay, we got 3 more cases we can go and do lah. Don't care lah. Can.
Can.
Next one, quick one.
All right, this patient comes to me with this type of rash. What do you think?
Psoriasis, discoid eczema. Okay, somebody else, come on, hurry up. We don't have time already. You have to say it now on dermatophytosis. Oh. Okay. This one. Tinea vesicular. Okay, tinea usually on the back, right? Tinea vesicular. Okay, come on. Anyone else?
Get the diagnosis lah. Can you see ring lesion? One ring, second ring here, third ring here. Okay, so this is tinea incognito. Tinea incognito. This patient, actually, after I get a proper history, she applies Dermovate on all the skin lesion. So ask to stop Dermovate, ask to stop clobetasol dipropionate, give her high dose itraconazole. Hopefully she gets better lah. She came back after 1 month of treatment. She gets a bit better already. She's like 40% better after 1 month of itraconazole.
Why incognito?
Oh, because incognito means the pattern is different. That's why you can see a lot of people say psoriasis, discoid eczema. If let's say the pattern is very, very nice, there is a ring, and then the inside of the ring is all clear, then all the doctors will say tinea corporis. So tinea incognito means the steroid changes everything.
Oh, because of the steroid.
Yes. That's why you can see multiple ring. Usually 1 ring. This one is 3-4 ring together. So this is tinea incognito. You need to treat this with itraconazole for at least 6 months. Then no more steroid. No more steroid cream. No more oral steroid. Nothing. Nothing to do with steroid anymore. Nothing to do with immunosuppression.
I see. So a simple case became worse lah.
Yeah, because of the treatment lah, and then she got Dermovate from a friend, and then keep on applying.
Okay.
So applying a cream is very dangerous in dermatology lah, if you don't know what's your diagnosis.
Ayo.
So next, this small kid, I think it's an 8 months or 9 months old baby, come and see me with this skin lesion. What do you think it is? Not painful, no symptom, nothing.
What's this?
Agak-agak lah.
Molluscum.
Yeah. Okay.
Molluscum. Anyone else?
Sometime already, it has been there for almost 3 to 4 months, not getting better. Tak ada beranak lah, just one only.
Somebody says scrub typhus. No
lah, no scrub typhus lah. Jarang ada lah scrub typhus. No. Mucosis, okay.
Mucosis, okay.
Bullous impetigo.
Too long history. 3 months cannot be bullous impetigo. So can you say it's a bit yellow here? I wanted to biopsy. The parent not keen in biopsy, so I cannot biopsy. So this one looks like xanthogranuloma.
Xanthogranuloma. Z-A-Z-X-X-A.
Xanthogranuloma. So xantho is yellowish, granuloma. This is a part of a solitary histiocytosis. It's histiocytoma kind of thing lah. Histiocytes, problem with the histiocytes.
So this is not dangerous lah.
Self-resolving. This is self-resolving.
Oh, I see.
So I told the patient it might be mother that this is might be self-resolving. We see how it goes because she refused biopsy, so I cannot touch.
Okay, so will it grow bigger? Queenie asked.
It might grow to a certain size and then you'll stop and then you'll regress. Usually it's self-resolving, no need to worry.
Okay.
Okay. The final one is this man who presented with this leg lesion, and then you see the eyes like this.
Okay, final one. Faster, guys. So tired. No, I don't know. Anyone?
Swollen eyes, staring eyes, leg indurated, painful, not itchy, red. What do you think? Usually we'll see another specialty in medicine and they will refer to you. But this patient happens to see me first lah.
Pretibial myxedema.
This is pretibial myxedema, thyrotoxicosis. This is thyroid eye disease, Graves' disease.
Wow, so clever, Dr. Parijat.
Yeah.
Dr. Parijat must be from Thailand, I think. Oh.
So this is pretibial myxedema. Okay. So, how do you treat pretibial myxedema in this case?
You treat the hyperthyroid.
It's all treated already. Everything go back to normal. He's even on treatment with our eye specialist. Everything clear off. When he's on steroid, all this will be better lah, because he was on steroid for the eye for a certain period of time. The skin all gets better.
Okay, so now you have to put him on steroid again now?
Yeah. So I give him intralesional steroids lah. Intralesional steroids much better compared to oral steroids.
How do you do intralesional steroids?
Inject on the leg lah.
How the eyes cannot treat lah?
On the thigh, I don't know. It's usually treated by our ophthalmology colleague. Myxedema, pretibial myxedema is hyperthyroidism. Myxedema is hypothyroidism. This is pretibial myxedema. Pretibial myxedema is something like your deposition of glucose aminoglycans in the skin. Yeah. This is almost always hyperthyroidism, almost always Graves' disease. So whoever goes for MRCP cannot diagnose this, sure fail one.
Oh, wow. Okay. We finished 15 cases. Well done. Okay, we can have another session one day. Because Dr. Felix.
Hopefully you all learn something. Hopefully you all learn something.
I learned a lot. Every time, but I learn and I forget. Oh yeah, so I need to share the QR code faster. Okay, we share the QR code. This QR code is for doctors, yeah? Only doctors. Okay, hold on. Let's do this. So, okay, I'm going to stop recording here. Then we share the QR code, yeah?